Okay, thank you for joining us today for the fifth workshop in our Safe at Home series, Successful Medication Management, Know Your UK RX Coalition. It's presented by Travis Albrecht, pharmacist and director of operations. In addition to providing information on the UK RX Coalition and its benefits, Travis is going to offer advice on medication compliance, some best practices for speaking with a pharmacist, potential adverse reactions with supplements, and much more. Travis, would you like to introduce yourself and get started?
Thank you. My name is Travis, pharmacist here with the Benefits Department at University of Kentucky, and happy to have everybody on. We can talk about medication, medication coverage, and a lot of major considerations when you need to have when taking a medication, talking to your pharmacist, talking to your prescriber, and different things. We're going to focus mainly on the Medicare space and retiree space because I think that's geared what most of the focus is supposed to be on for this. So that's going to be the main point of focus is kind of in our Medicare space. And I just kind of want to kick it off with if you do have any questions or something doesn't get answered, feel free to reach out to us. You can hit us directly at kyrx@uky.edu. Also, I'll keep eyes on the chat. So if you have some questions, I know people are on mute, but if you want to put a question into the chat, I'll be monitoring that and can either speak to it or just reply directly to you in the chat there. So without further ado, I will jump in kind of explaining our overview of things. Which benefit do you have in the retiree space? There's kind of two different ones. There's the Medicare and then the just the pre-65 retiree. We're going to look at an overview of coverage of medications. And the reason that we're going to spend kind of a considerable amount of time on what benefit you have in coverage overview is because that one of that biggest common barriers to medication is obtaining the medication, right? So the best medication in the world is useless if you can't afford it, or it's not covered, or you can't get it, or you don't know how to get the medication. It's kind of useless if you don't have the medication to take. So once we get that medication in hand, then we can talk about adherence factors, best way to take your medication, best time of day to take your medication, and all those types of things. More importantly, when you're talking with your prescriber, your pharmacist, what information do you need to be relaying to them so that they can make more informed decisions about what therapy to use? And at the very end, I have some information about some cutting edge kind of new therapeutic things that we are working with in the Medicare space here at University of Kentucky and the teacher retirement system of Kentucky. And that kind of falls into, who can help? Your pharmacist can help, your doctor can help, your neighbor can help if if your neighbor happens to be a doctor or pharmacist. So we're kind of hit on all these things as we walk through this next little bit through the seminar and hopefully have some good information for you guys to take away. One kind of overview before we get too far into it, the Know Your RX Coalition, some of you may be pretty aware of what we do. We work with all the members of the UK retiree, UK active, UK Medicare group. We interact with all those groups to help the patients kind of successfully navigate their prescription benefit. I already touched on this once, one of the most important things of getting the medication is navigating your benefit there. So we're a group of pharmacists that you can call us and you call the number, phone tree says you can press one to leave a voicemail, and then if you just let it ring, a pharmacist will pick up the phone. And then you can even request the same pharmacist you talked to last time. So you can call back and talk with Allison every time you'd like, or talk to a different pharmacist every time. But we're here to really help patients offer that hands-on touch, not necessarily replace, but complement the existence of, that retail pharmacist that you have there at Walgreens or Walmart or wherever pharmacy that you go to. So we'll just hit on the benefit stuff real quick. It's kind of broken in, if you're a retiree, it's broken into two different parts, that pre-65 retiree Medicare group or non-Medicare group. And that benefit looks just like the actives working here on the plan here at UK. And then the retiree Medicare group, that's the members who are in that Medicare eligible health plan, sometimes referred to as MEHP, EGWP, goes by a couple different names. But those are the two kind of classifications that we look at when we're working with members. For the pre-65 members, you have a card, Express Scripts card, for all the different plans. This is what you'll show at the pharmacy. Your spouses and dependents are covered under the same ID number. They don't have a separate card. And this is all administered by Express Scripts. Actually, both groups are administered by Express Scripts, but you'll see that kind of logo on your cards and it shows up in your mailings and things like that. But that's the group that is managing, administering. We're managing, but they're administering the prescription benefit on our behalf. That'll make sure that when the claim processes properly, any prior authorizations are addressed, and you have a co-insurance or copay associated with the medication, that the intention is to make sure that it's going to be an affordable cost, so it's not a barrier to therapy. Medicare benefit, your cards will be branded with the Medicare name, so that the pharmacist knows that it's a Medicare plan and can take necessary steps if they need to locate any more information about you or the coverage of your medications. Not going to spend too much time on this because this doesn't really have a whole lot to do with safe medication administration, but I think it's important to have in there just in case anybody does have a question who is part of one of these plan members, that when they're looking at things, if you're an active employee or a pre-65 retiree, how things change when you move into the other group. And then in our UK Medicare plan, like I said earlier, it's that egg whip, and that's a wrap coverage. Basically, it's a standard Medicare plan. So you have your standard Medicare Part D coverage and benefits and everything, and this wraps around it. So UK offers a subsidy over top of the Medicare that's available and subsidizes a lot of the cost for the members to ensure that medications are affordable, more affordable than the standard Medicare benefit, that you're not left hanging out in some situations with some enhanced coverages on Medicare Part B and things like that. And new for 2025, and this will also be in place for 2026, is that there's no such thing as a donut hole coverage gap anymore. We also don't have a deductible. So you move straight from having coverage, and then once you spend X amount of dollars on prescription drugs or medication cost, then you go into $0 cost for all covered medications the rest of the year. That does reset every year, January 1st, regardless of when you enter the plan. This is an explanation of what that troop value is, true out of pocket, things like that, as we move through the plan year and what cost is. These are the 2025 numbers that are applicable to all Medicare plans. And what I was talking about earlier with the subsidy, you have no deductible, whereas the main benefit there has a $590 deductible. UK covers that deductible for you. 25% cost share, UK lowers it to 20%. And then on brand name drugs, they have maximums. So you never, while it 40% seems more than 25%, you have a max of 60. So you kind of have a ceiling and kind of a security blanket there as you move into more costly drugs. And then that out-of-pocket threshold, once you hit that number, you have no more cost share the rest of the year, which is a great thing for obtaining your medications. It's no longer a barrier to entry. This is a program. It was initially rolled out as a cost-saving thing for members in the Medicare plan, where you would pay nothing for your medications at the pharmacy. It would rather be billed to you over the remainder of the year. So if you got an expensive medication in January, it would be billed to you throughout the remainder of the year over the next 11 months. Or if you got one filled expensive in October, it would just be billed out evenly over the next 2 months. This is something that I would like to warn Medicare members about, that if you're at the pharmacy and you're asked to sign up for what's called the M3P program, that it's something you do some math and some homework on. We have pharmacists here who are ready to help navigate that. But what can happen is that first cost has a maximum, but future costs don't have a maximum cost. They could be whatever the monthly cost ends up being. So what it can happen is a balloon payment at the end of the year. And we don't like to see our members end up with costs that continue to get more expensive throughout the year when it should be working kind of the other way, where costs should be decreasing throughout the year. So this is something that I would recommend be a bit weary of. And if you are asked to enroll in by the pharmacy or anybody else, feel free to give us a call or do some homework to make sure that your cost isn't going to go up as the year goes on. Everybody's head is probably going to be spinning if you see something like this with regards to Medicare Part D coverage. There's a lot of different factors that come into play. Many of you have probably heard about stuff like this, low income subsidy, uh, or late enrollment penalty, IRMA, explanation of benefits, things that get mailed to you every month, self-administered drugs. Uh, all these things can cause a lot of confusion with members and cause a lot of confusion that can make being a Medicare Part D enrollee quite cumbersome. Just realize that you have a pharmacist here at your disposal that can talk with you and walk you through things. And we have plenty of resources on our end that we can help members navigate a lot of this. Now we can talk about how this comes into play with your actual medications. And this is where we'd like to spend, most of our time. And why I went through all of that was you cannot take a medication you cannot afford. You cannot take a medication that you cannot obtain. So having, a pharmacist that you can talk to, whether it's your local pharmacist or somebody here at KYRX, can be critical in making sure that you consult with them when you do get a new prescription that possibly, it's only available through a specialty pharmacy. Could your medication only be available compounded, meaning that the pharmacy has to take tablets and liquids and mix them all together and manufacture this solution, this topical cream or something that you wouldn't be able to obtain at your local pharmacy? And how do you prepare for that, knowing that you can't get the medication right away? Or am I going to have to find a compounding pharmacy? Those are a couple of things that you need to keep in consideration. One of the best ways to get a maximum benefit out of your medication is to be adherent. A lot of every time they do drug studies and everything, it's based on adherence and how they dose the medication. So if it's once daily dosing, the intention is you're taking that medication every 24 hours. The dose and how the average person metabolizes that drug is all dependent on taking it about every 24 hours so that you get that steady state of drug in your system and you're not at situations where you took it at night one day and then the morning the next day you're going to have a spike in drug levels and you may have more subject to adverse reactions of the drug because now you have more drug on board than the intention. And then you back that with another daily dose, do it again the next night, and you kind of went 48 hours without the drug, and then you're experiencing subtherapeutic, so not enough drug on board. So taking the medication as directed every 24 hours, or if it's twice a day, every 12 hours, is one of the more important things to do. Now, I've been asked a couple of times, what's the best time of day to take my medication if it's once daily medication? The answer to that is not a concrete answer, but my favorite answer is whenever it's best for you that you will remember. I know some patients were on cholesterol medication and their doctor, their pharmacist told them, you might want to take this at night because it can cause a little bit of muscle aches in some patients. Well, that's only about 1 to 2% of the population would experience those effects. But the patient, he wouldn't remember to take his medication at night. The best time for him to take the medication was in the morning because that's when he kind of had his routine. He did the Wordle, took his medication, and had his coffee every morning. That was kind of how he did it. And then when he was directed to switch it to night, he kept missing doses. So we went back to switch it to taking it in the morning. He did not have any of the muscle aches and pains, none of the drowsiness or anything. He was part of the 98%. And he was good to move forward with taking it, and adherence really improved. So my favorite answer to that is take it at the time of day that's you can remember to do it at the same time every day. Another important thing to do when you're working on a medication or taking a medication is taking it on a full glass of water. So when we take medications, again, the study's a distribution throughout the body. So that's basically when you take a medication, it goes into your stomach, and then your stomach starts doing what it does to the medication and dissolving it, and your body starts to absorb it from there. Medication will go through what's called first pass metabolism through the liver. In some cases, it gets turned into another drug. So what you take isn't what's actually taking effect on your body, but your body turns it into a more useful medication that then impacts your body. Other cases, the liver doesn't do anything, and the drug just disseminates throughout the body. An important part of that is when drug doses and drug studies are designed, patients take it with a full glass of water. My grandmother's notoriously just takes enough water to swallow the pill, and that's it. And that can lead to things like GI upset and subtherapeutic dosing of the drug. So taking it with a full glass of water every time you take your medication is one of the most effective ways you can make sure that you don't have GI upset and you're getting the full effect of the medication based on how the medication was designed and studied. That isn't to say you have to take, a full 8 ounces for every pill you take. So let's say you take a thyroid medication and um, a PPI medication and maybe something else for mental health. You have to take 3 full glasses of water, but having a full glass of water to go with all your medications that you're taking at the same time is extremely beneficial for patients. Oh, sorry, I jumped ahead for a moment. When you're talking with your prescriber or your pharmacist about medications, some things that often get overlooked are herbals, so herbal teas, uh, St. John's wort, anything like that. Those often get overlooked when we're doing a medication history. So, talking with your prescriber or pharmacist, it's important to give them everything that you take on a regular basis. That way, we know we can put things into the system and we can look at things to make sure that we're not potentially setting the patient up for an adverse drug reaction, drug-drug interaction that can be detrimental to the patient, to their health, lead to failure of our intended therapy that was maybe being used to decrease cholesterol, but ends up cause a lot of muscle aches because you're on another medication that increases the therapeutic effect and leads you into adverse effects for the cholesterol medication. So giving a full medication history, whether you think it's relevant or not, is always helpful to the pharmacist or the prescriber who's taking that medication history. In some niche cases, it's also extremely important to talk about your diet. So caffeine intake, nicotine intake through smoking, chewing tobacco, vaping, anything like that, those can have serious effects on medications for cardiovascular issues, for mental health, for addiction medications. It can be very important to give all those medications and all those substances that you intake. One thing that's really interesting uh, is how vitamin K is extremely present. It's high doses. Vitamin K is in mayonnaise. So worked at a warfarin clinic where patients take a medication. It used to be very popular, not so much anymore, but it was called warfarin, and it thinned your blood more or less. And you had to go in every week or every 2 weeks, and they would draw your blood levels and determine how prone you were to clotting to make sure you didn't have a stroke or a heart attack. And one thing that we always had to ask patients is if they changed their diet as far as spinach, which has a lot of vitamin K, and mayonnaise. And we had, a handful of patients that their INR and vitamin K would have wild fluctuations based on what their diet were. And it's not that you had to give it up or anything like that. You just had to be more consistent for some items. So even getting into your diet and how lifestyle factors. that can play a huge role in medication and how they interact with your body, more so than what we would expect in some cases. Another item that I want to hit on, this is more of a cutting edge therapy that we've been working on for the past few years. It's called pharmacogenomics, and this is something that for the Medicare population at University of Kentucky, this will be available to retirees in 2026 as we look at things. Uh, but to put it really simply, when we look at drug approvals, and I've touched on this a handful of times throughout the presentation, that medications, when studied by big pharma or goes into trials and things like that, they take the drug and they're studying it in tens of thousands of people. And all that information is aggregated, and we kind of look and we kind of boil it down to what does the average patient look like, and what does this drug do to the average patient? And that's where we end up with, all right, 10 milligrams of this drug, we would expect to lower somebody's A1C, which is a diabetic marker, by zero point 0.5 points. 5 milligrams, we would expect it by 0.25 points, or 25 milligrams, we'd expect this. So that's how we kind of get those clinical guidelines of what dose to start somebody out of. And we're looking at, 10,000 people aggregated into one. And that's what we would expect to happen. In pharmacogenomics, we've turned that around and we say, what do you, the patient, do to the drug that could change how we dose it? And this all ties back into medication history and lifestyle factors as well, that we can look at a patient's DNA and we can determine how they may impact the drug differently than the vast majority of people. So maybe we want to start on a different dose or a higher dose or a lower dose that would be more effective for you as a patient. What also plays into that is you could be on a medication, or you could be a high consumer of certain types of dark chocolate that alter your metabolism of a drug, similar to what we would see with a change in your genetics. So maybe you typically would metabolize the drug just perfectly fine, but you're a smoker, so you metabolize the drug a lot slower, and we would need to give you a lower dose so you have less adverse effects. So this ties back into, while PGX has given us a glimpse on having um, really targeted therapies and targeted dosing, diet, lifestyle factors can have the same impact that your genetics have on the medications. And that's why it's so important to go over your medications with your pharmacist and give them all the information. Those are some of the high level kind of drug topics that I would definitely pass along to any family member or any patient who just kind of wants to know, if I'm starting a new medication, what would be some of the things that I would want to consider? One, make sure you're taking it at the appropriate time every day. If it's once a day, make sure you take it at the same time every day. Twice a day, still same time, but that best time is the time that you can remember. Two, make sure you're taking oral medications with a full glass of water. If you're not taking an oral medication, let's say it's an injection or a topical or something like that, be aware on topicals the difference between creams and ointments. Big thing with creams is they're water-based and they're going to go into your skin a lot faster, and you can probably put some dressing or sleeves over it a lot sooner, whereas an ointment is going to be oil-based and it's going to need to be exposed a little bit longer, and it can be transferred to other patients. Looks like a question just popped in. Older adults are often have a number of specialists for chronic conditions and being prescribed medications. How do you ensure you're not being overprescribed? One big thing that we kind of have an advantage of here in a pharmacy benefit is, while people may go to numerous specialists, let's say a mental health specialist or rheumatologist, and then your general practitioner is everybody wants their kind of drugs to be covered by insurance. So we kind of see all those claims come through. We do a lot of outreach to members. So if you ever get outreach from your pharmacy or your pharmacy representative, take the time to talk with them and go over medications. This also goes back to if you're not going to be using the same pharmacy, if you're not going to respond to those outreaches from the pharmacy benefit or anything like that, is to take the time to talk with your doctor and carry a list of medications that you take anytime you go to any of your doctor's appointments. It can be very easy just to keep a short list of the name of the drug, the strength, and how often you take it. Having something very simple like that you can show each one of your prescribers so they're aware of what you're taking, and then also jot in there any any lifestyle factors that could be relevant, or make sure they're brought up in conversation. Definitely any herbals or supplements or over-the-counter items are a common omitted thing that a lot of patients may not tell their doctor that, oh yeah, I also take an aspirin every morning, or I take 4 ibuprofen twice a day because my back hurts so bad, but I didn't include that in my medication history because it's not prescribed. So I don't need to put it on there, right? No, over-the-counter medications are still important to report to your doctor and your pharmacist when we're looking at therapy changes or just continuation of therapies. Question on here is my mom would often forget to take her morning med, so she would take two in the afternoon. She would also frequently drop a pill and not realize it because her hands were numb. It was challenging to keep her compliant. Whenever, it kind of depends on the medication in some cases. Um, Typical, most of the medications, if you ever forget to take a medication, um, you typically do not double up if you're taking your next dose and you realize that you forgot your previous one, that you would just continue your medication. You would not double up and take the next dose as directed and just continue to go on through. That's the most common strategy when taking something like antibiotics, because those are typically dosed 2 to 3 times a day. That if you forget, if it's the evening and you forgot your morning dose, you do not double up. You just continue to take the medication as directed until you're out of the drug. So that's one thing, is not doubling up on medications if anything is lost. As far as keeping track of your medications and pills, some pharmacies do offer sort of a pre-pack situation where they will bundle all of your morning medications in a little tiny baggie. So that way, you just have to cut it open and you have all your medications right there. Using pill boxes that you can put all of your Monday morning doses in one box, Monday evening doses in another compartment of the box are very common. And those are widely available on Amazon and anything like that. I highly recommend using those. I actually have one right here that I use for all my vitamins. And then another strategy that members use to make sure that they're constantly reminded of when to take their medication. Setting up reminders on your phone. So if somebody has, like in the question in the chat about their mother, you can, if they have a smartphone that they use, you can jump into their alarms and set an alarm on their phone that has a custom title. And when it comes across, it'll say, take your simvastatin, take your synthroid when this alarm goes off. It just offers, it's kind of a reminder that can be there for you when maybe you can't be there to help out an elderly patient, and kind of there for you when you're not. And then it'll remind that member or that patient to take their medications, and it can really increase compliance, which is the best way to get the full effect of your medication. One thing that is big is about leaning on your pharmacist, whether it's there at the retail pharmacy, and giving them any sort of adverse effects that you're experiencing from the medication, and keeping track of what you're expecting to get out of the drug. If you're expecting it to lower your blood pressure, then your doctor may ask you to purchase a blood pressure cuff monitor, something that you monitor every day and take your blood pressure. Keeping logs of that and giving it back to your doctor can keep them on track of what your blood pressure is doing in the 6 months or 3 months in between visits. If they're only taking your blood pressure as a snapshot in time, it could be elevated due to, seeing a doctor. That white coat syndrome can be very real, that patients get nervous, blood pressure goes up when they see the doctor, but when they leave, everything's fine. So taking your blood pressure at home is something that can be extremely beneficial for your own medical records and to kind of taking control of your own health and ensuring that you're getting the benefit from the medication. And if we expect to see normal blood pressure, what is normal blood pressure? 120 over 80? That's definitely normal. But maybe you have very high blood pressure, and our first goal is to get you down to 130 over 90. And we're not trying to hit normal blood pressure at this moment. We're just trying to get you a little bit lower than where you are to get you safe again. So knowing what the intention of your medication is can also be very helpful. So you can be on the outlook for what sort of outcomes should I be seeing, or what sort of things should I be aware of. If you ever pick up a new medication, definitely ask the pharmacist any adverse effects I should be aware of. They are readily at their fingertips. They should have everything to tell you what the most common adverse effects of the drug are. Maybe it's um, drowsiness. Maybe it's a dry hacking cough. There's a really popular medication, lisinopril. It's been generic ever since I can remember, and it's very, very cheap and very, very effective in about 10% of the at lowering blood pressure to a healthy, safe range. In about 10% of the population, if they take this medication, it'll cause this kind of dry, non-productive cough. And one time at the pharmacy counter, I was talking with a patient and they weren't complaining of any adverse effects, but you could hear the cough in talking with them at the counter. They kind of excused themselves a couple times, and I was able to identify you're on lisinopril. Let's talk with your doctor, and we can move it over to another class of medications, just as effective, just as inexpensive, available generically. And we were able to get the patient switched over to another drug, and 2 weeks later, the cough was gone. Something that they may have been struggling with for a couple weeks, if not a couple months. Um, and we were able to get it fixed relatively inexpensively. So make sure no one piece of advice is, nothing's too small. So a lifestyle factor, a nutritional habit, your dietary habits, nothing like that is going to be too small to mention to your prescriber. Uh, Over-the-counter medication, herbals, anything like that. So it's all relevant to bring to the attention of your healthcare professionals that you work with, so that they can make more informed decisions about what's going on with you and help maximize your health. Bit of a plug for our group here at UK. If anybody is here, I understand a handful of you may have jumped in to get some advice about how to take care of an elderly loved one, or even a young loved one. So maybe a child that you take care of and may have some polypharmacy or a lot of medications, and looking at things like that. Um, if you are a UK member, feel free to give us a call. The patient doesn't have to be a UK covered patient. We're pharmacists here at UK, and if you have just kind of general questions or need some guidance on taking care of your loved one, feel free to give us a call, and we can give you some pharmacist approved advice. Oh, looks like something came through. What should we watch for as our loved one ages? And are there concerns about how aging affects medications? So one thing that I've seen with one of my loved ones, as she got older, she got a little bit less balance. So one common medication class in Medicare is actually called the Beers criteria. It's BEARS, I believe, but it's a list of medications that in a younger uh, population is not as much of a concern, but as we get older, we're a little bit less stable when we're walking around. We have, our utilities there like canes and walkers and stuff. Um, but it's medications that you need to watch out extra close for drowsiness and monitoring. So if you ever hear about a Beers List drug, and those are often flagged for elderly patients at the pharmacy for the pharmacist to talk with that member. So if you think you have a loved one who could be on a medication that could cause unsteadiness, that could cause loss of balance, ask your pharmacist if they're on a medication that happens to, and if it can be exacerbated by other medications the member's on. Somebody has a question about daily famotidine. Um, with those are kind of like stomach medications that have issues with regurgitation and kind of just the GI upset, heartburn, things like that. If it's something that the patient is needing on a daily basis, then it improves quality of life. But typically, that medication is usually only used for 2, 3, 4 weeks the most to get through if there was just a bad couple weeks of eating or poor diet choices that we can get back on track and we don't necessarily need that medication. There are a few indications. Esophagitis could be one of them that a patient would need a medication like that just to be able to consume food. I'd say most people aren't using famotidine for that, and it is something that a patient could stop taking. I'm a proponent of let's not put a medication on board until we need it, and then if we do need it, let's have an exit strategy for how long do we need to be on the medication? Can we taper off of it? It's one of the big things with sleep medications. I think, and this famotidine example or proton pump inhibitors. So I'm sure we've all heard of Prilosec and omeprazole. Those medications are typically only supposed to be used for 3, 4 weeks, um, and discontinued, and make whatever life changes needed to avoid having those heartburn effects. And patients sometimes get on those medications and they're never taken off. Same thing with sleep medications, which can be even more critical in our elderly population, especially in female elderly patients. Medication Ambien, generic name is Zolpidem. The starting dose for females across the board, across all ages, is half the dose, because the way that females metabolize that drug is in a different way and a lot slower. So you're exposed to the drug a lot longer. Unfortunately, that was discovered as a lot of female patients on the medication were driving to work the next day and putting themselves at risk. And then cutting the dose in half, they saw the same therapeutic effect with fewer risks the next day. So definitely a good question. And de-escalation is always a good thing to have in mind with a medication. Some medications are, it's something that it's a chronic condition. You will need to take it to manage that condition. Something like metformin for diabetes or Jardiance, you don't typically have an exit strategy on that medication. But for something like a sleep disturbance, getting you back on cycle, a GI medication to help you get through a bad dietary session, those are things that we may want to consider having an exit strategy on.
Okay, well, if there's no other questions, Travis, this has been wonderful. This has been really good. I really appreciate all the advice and the tips and the things that we're concerned about, getting some direct answers to that. That's wonderful. So I want to thank you very much and appreciate you being there.
Thank you guys for the invitation. I know I spent a lot of time on drug coverage and cost and stuff, and that's kind of what our bread and butter is. And I'll go back to that. You can lean on us if you're a member of UK, or even if you're calling about somebody who's not a member and you just want to ask a pharmacist some questions, we're here to help. So, and we're part of the benefit. So there's no cost, anything like that. Just reach out to us and we're here to help.
Okay, great. Thank you, Travis. Appreciate it.